And the next topic is the ever enigmatic topic of recurrent implantation failure. Over the last 4 decades, we have seen tremendous developments in the field of ART. Still, the implantation continues to be a bottleneck or a black box of the assisted reproductive technology. And whenever a patient comes to us with a report of beta-SHG negative failure, it's a feeling that all of us want to hide because there are too many questions and no answers. And today we have the brilliant scientist from Egypt, Professor Abu Bakr El-Nasher, to answer all these questions and decode the doubts and confusions that we have about recurrent implantation failure. He is a professor of obstetrics and gynecology of Benha University Hospital, Egypt. He is the member of the Egyptian Board of Fertility Society. He is also the president of Clinical Society of Obstetrics and Gynecology, editor of Middle East Fertility Society Journal, Egyptian Fertility Sterility Journal, Benha Medical Journal, and he has 34 international publications, invited speaker in international conferences like ESHRE, RCOG, European Congress of Obstetrics and Gynecology, etc. He is an invited speaker in 8 countries, author of 4 textbooks, and co-author of 7 textbooks. So here I present to you the brilliant surgeon, the ever-smiling, well-spoken Professor Abu Bakr. He is a very popular person, and I have been admiring his work for a long time. So I thank Dr. Reddy for having brought him to this platform, and we are all waiting to listen to you on the strategies to manage recurrent implantation failure. So here I present to you Professor El-Nasher.
Thank you very much. Can I share my
Yes, sir.
slides, please?
Put in the slideshow mode.
Yes. I would like to thank my dear friend and dear brother, Professor Reddy, for this kind invitation. And you can find this lecture and more than 455 lectures on my scientific page on the Facebook. And the first time to visit India was in 2017. And second one was in 2018. And third one today. Today I will discuss the management of recurrent implantation failure. And I will stick to the very recent guidelines of the British Fertility Society. First, as we know, 5 to 7 days after fertilization of the oocyte, and continue up to 22 weeks of gestation. The implantation rates per embryo transfer is only from 20 to 30%. And the cumulative live birth rate after 3 cycles of IVF from 42 to 57%. And after 6 cycles from 44 to 75%. There is no agreement about the definition of repeated implantation failure, but simply it is failure to conceive after repeated attempts of IVF. The number of failed attempts has not been universally agreed. But we should differentiate between recurrent implantation failure and the recurrent failure of ART, which may be due to patient characteristics and include scenarios where no embryos are transferred or due to treatment protocol failure. Let us go to see what is the definitions of repeated implantation failure. After 3 consecutive embryo transfer of at least 4 good quality embryos in a woman under the age of 40. Another definition, after only 2 consecutive embryo transfer of at least 4 good quality cleavage stage embryo or 2 good quality blastocyst. But what is the definition adopted by the British Fertility Society? Very simple one. Absence of positive pregnancy test after 3 consecutive embryo transfer of good quality embryos. The incidence is variable, but about 10% of the cycles, and it is very important to discuss it because its impact is the stress of the couples, frustration of the doctor, and increase the cost of the procedure. The management is challenging, not only for the clinician, but also for the embryologist. There are many methods for classifying the causes of recurrent implantation failure. What is the best and the very clear one? We have 2 layers. We have the endometrium and the embryo, and we have other factors. So we can classify the causes of repeated implantation failure into endometrial causes, gamete embryo causes, and other or multifactorial. But we should keep in mind, maybe a combination of all of this. Let us just to see the endometrial factors like anatomical one, polyp, fibroid, submucous fibroid, adhesion, severe adhesion, septum, infection, chronic endometritis, vaginal or uterine microbiome, where there is a low abundance of endometrial lactobacillus. This may be anatomical, but it may be physiological, impairment of the function of the endometrium if it is thin, or there is alteration of the expression of adhesive molecule, thrombophilia, immunological factor. This is the first layer, the endometrium. Either it is anatomical or physiological. What's about the second layer, which is the gamete? Parenteral chromosomal anomalies, poor quality oocyte, poor quality spermatozoa, zona hardening, suboptimal culture condition, suboptimal embryo quality. So this is the 2 layers, the endometrium and the embryo. What about the other factors or the multifactorial factor? Suboptimal ovarian stimulation, suboptimal embryo transfer, hydrosalpinx, endocrine causes, and the endometriosis. Let us go back to the guidelines of the British Society, British Fertility Society. It was very clear and very sharp, and adopting the traffic light rating, classifying it into red, where there is no evidence to show that it is effective and safe, and amber or yellow, where there is a conflicting body of evidence for this ad, and further research is required, or green, where there is more than one good quality randomized controlled studies which shows that the procedure is effective and safe. So we can, it is red, that's to say not to be done, where there is no evidence for efficacy or safety. And it is yellow, where there is a conflicting evidence, and it is green, where there is a good evidence. So no evidence, conflicting evidence, and good evidence. Let us go what is meant by management. By management, we mean investigation and the treatment. And we'll stick to the same protocol in the investigations and treatment. The 2 layers and others. The endometrial investigation, investigation for the embryo, and the investigations for the other. Let us see what is the guidelines of the British Fertility Society. An evaluation of the pelvic anatomy for detection of Müllerian anomalies using 3D ultrasound is recommended. And there is no evidence to support use of hysteroscopy in absence of suspected uterine pathology in the first cycle of IVF. What is about the ERA test? ERA test with individualized embryo transfer is not recommended. Testing for infection disorders, there is insufficient evidence to recommend microbiome testing. But if infection such as tuberculosis is diagnosed, treatment should be given. Testing for immunological disorder, there is insufficient evidence to recommend uterine natural killer cell, peripheral natural killer cell, endometrial and peripheral blood cytokine testing, HLA incompatibility testing. It is not recommended at all. Teaching, there is insufficient be the last resort and should be avoided because it will initiate uterine contraction, but according to the guidelines, there is insufficient evidence for or against use of tenacula. There is insufficient evidence to recommend cervical dilatation in setting of previous difficult embryo transfer, but if it is performed, it should be done in the prior embryo transfer cycle, not on the day of embryo transfer. If we do it in the day of embryo transfer, the actual embryo transfer, it will decrease the implantation rate. And there is no evidence as regards the bed rest. There is a good quality evidence that bed rest after embryo transfer doesn't significantly affect the live birth, but the reverse is present. There is some evidence that bed rest may have a detrimental effect in embryo implantation rate. There is insufficient evidence to recommend the use of fibrin sealant or antibiotic after embryo transfer. It will not increase the implantation rate. And there is no evidence that relates specifically to cases of recurrent implantation failure. There is evidence of use hyaluronate enriched culture media to improve the live birth rate in unselected population, but again, no clear evidence specifically for women with recurrent implantation failure. There is insufficient evidence to recommend use of elective frozen embryo transfer with recurrent implantation failure. Additional data on multiple pregnancy rate are required to understand the role of sequential embryo transfer in cases of recurrent implantation failure. What is about the ovarian stimulation strategies? There is no evidence to indicate recommendation of a specific strategy for controlled ovarian stimulation. The evidence of hyaluronate enriched culture media to improve the live birth rate in unselected population is present, but there is no clear evidence specifically for women with recurrent implantation failure. There is insufficient evidence to recommend routine elective frozen embryo transfer. I think this is a repeated one, sorry. There is a strong evidence to recommend laparoscopic salpingectomy in a case of hydrosalpinx. And how to optimize the endocrine condition? If we have subclinical hypothyroidism, thyroxine is indicated, and our objective is to keep the TSH between 0.5 to 2.5. And if we have euthyroid with presence of thyroid autoimmunity, there is no indication to give thyroxine. But in this condition, we should follow up the patient when she gets pregnant because she is high risk to develop hypothyroidism during pregnancy. There is insufficient evidence to recommend treatment of hyperprolactinemia for women with a history only to improve the pregnancy outcome. To come to the conclusion, as I mentioned, it is very clear. It is the traffic lights, red, yellow, and green, and will review what is mentioned in the same way. The investigation for the endometrium, it is recommended to do 3D ultrasound, while screening hysteroscopy and the ERA not recommended. The uterine natural killer cell, there is insufficient evidence. The peripheral natural killer cell, the uterine cytokines, the peripheral cytokines, genital microbiome, HLA incompatibility, not to be done. And for the antiphospholipid antibody screening, there is insufficient evidence. And for congenital thrombophilia screening, not to be done. Sperm aneuploidy and DNA fragmentation testing, there is insufficient evidence, and that's why it is yellow. Sperm epigenetics and the CASA, not to be done. AMH, insufficient evidence. And genetic testing, karyotyping, not to be done, but it may be indicated if we have a high order repeated implantation failure, that's to say more than 6, or if there is an additional risk factors, that's to say repeated miscarriage. Hydrosalpinx should be removed, and screening for TSH is recommended. Thyroid antibody testing there is insufficient evidence. The prolactin, the free androgen index, and hemoglobin A1C not to be done. For the treatment, polypectomy and the myomectomy for submucous fibroid is recommended. Septoplasty, there is insufficient evidence. And all of this is not recommended. The sildenafil, the granulocyte colon stimulating factor, and BRB are not recommended. Endometrial scratching and corticosteroid, insufficient evidence. IVIG not to be given. And counseling, including genetic counseling, is highly recommended. Antioxidant, hyaluronic acid binding for sperm selection, MC, surgical sperm retrieval in absence of isospermia, not to be done. Blastocyst transfer, insufficient evidence. Assisted hatching, time-lapse imaging, and pre-implantation genetic testing for aneuploidy, not to be done. Donor gamete surrogacy, not to be done. Smoking cessation, optimizing weight, and the vitamin D supplementation is recommended. Ovarian stimulation, particular protocol, there is insufficient evidence. And lastly, to improve the embryo transfer to be done under ultrasound guided and to have a full bladder. For the catheter tip should be more than 15 millimeter from the fundus. Cervical dilatation, hyaluronic acid embryo transfer medium, insufficient evidence. That's why it is yellow. Cervical mucus removal, bed rest, fibrin sealant, antibiotics, frozen embryo transfer, sequential embryo transfer, not to be done. Treatment of subclinical hypothyroidism and treatment of hyperprolactinemia, when indicated, is recommended. Removal of the hydrosalpinx by hydrosalpinxectomy, and that's all. And this was the picture when I was in Salem in 2018. Thanks a lot for your attention. And if there is any questions, I am ready to